Hello, my name is Dr. Ford Kazazi, and welcome to part 2 of the Embryology Made Easy crash course for medical students. We discussed in the last part the processes of fertilization, implantation, and gastrulation, and we spent some time focusing on ectopic pregnancy and the importance of that clinically, and the embryological processes that allow us to identify it as a disease process. Today we'll be discussing segmentation, folding, and neurulation, and let's get straight into it. So segmentation is a process of constructing a linear series of repeating parts, each being a segment. This will establish the primary body map, what you'll know clinically as the dermatomal distributions. And this process starts at day 20 and continues through to day 28. And you'll see these condensations of para-axial mesoderm. Now, in exams, often it's assessed, which germ layer does a structure belong to, and specifically sometimes they'd like to know which segment of mesoderm something comes from. So we're talking today about somites. And if you think about the axial skeletal structures that they form and also the vertebra, it makes perfect sense that the mesoderm which is utilized here is the para-axial mesoderm, the mesoderm closest to the central dorsal axes of the trilaminar disc. But the process of segmentation, it first starts cranially and progresses caudally with 3 to 4 paired somites forming each day, up until a number of about 44 from the occiput base, to the embryonic tail. And so in humans, the caudal, 5 to 7 disappear, and so we don't have tails like other mammals. But this process of I suppose the end product through the vertebra and them as a repeated, very very slightly differing repeated pattern was actually documented multiple times in the last few centuries pre our understanding of segmentation neuralation, as a lot of scientists realized that where there is such homogeneity between the parts of the spine, it suggested that something was happening that was repetitive and segmented to be able to form this process, because the alternative would be forming a whole spinal structure and then dividing it into 37 different slightly different vertebrae, which obviously mechanically would be a more challenging process to undergo. So each somite, each condensation of paraxial mesoderm is an independent unit, and what's going to happen with those is that they're going to form the axial skeleton. So this is the vertebra and the ribs, not the associated limbs. And they're going to form the associated muscles and overlying dermis. Okay, this is key because our ectoderm is going to form the epidermis, but often people will just say, the ectoderm forms the skin. Well, actually, no, the ectoderm forms the epidermis. The axial skeletal dermis, particularly, is formed from the somites. Okay, so it's formed from the mesoderm. And again, these small subtleties I was talking about before are often assessed in exams because they're a good way to differentiate between candidates. The limbs are going to form from transcription factors which are secreted by our somites. There are lots of really impressive experiments with llamas and with salamanders and snakes where you can change these transcription factors and alter the location and the orientation of the limbs that form. But what's key in this process is to remember actually that these somites will also form the occipital part of the skull. They're going to form the bones around the nose, the eyes, and the inner ears, and the ocular muscles and muscles of the tongue. So effectively, it's going to form everything from the skull base down to the sacrum and the coccyx. And the bit that's excluded, and again key for exams, is that the skull vault does not form from the somites. And that again, it comes back to this idea about key exceptions that are assessed. The first 4 somites are going to form this occipital skull base and cranial structures. Then there'll be 8 cervical somites, and we'll discuss in the next slide why that's key. 12 thoracic somites, and then 5 lumbar and 5 sacral, and obviously the sacral fuse to form the sacrum. Now, clinically, you will hopefully recall that there is a C1 to C8 nerve root, but C1 to C7 vertebra. And so often people, clinically we know that the nerve root comes up out above the vertebra at every level, and then below C7 it starts to come out below, such that C1 comes out above the C1 vertebra, but T1 comes out below the T1 vertebra. Okay, and the reason for this is this process of somite polarization and re-segmentation, where effectively the cranial and caudal aspects of each somite express different sets of genes, and as a result of that have different cell densities. So the cranial aspect of one somite is going to adjoin with the caudal aspect of another, leaving behind this fissure, von Ebner's fissure, and it's along this groove that the nerve roots pass through. And this is why I say that the C8 vertebra is missing, but if you think that there are 37 somites, and at some point, if we're taking the top half of one and the bottom half of the other, at some point we're going to lose a somite. Okay, so it's at some sporadic point, random point, we'll lose a somite, and the point at which we do it for understanding is the C8 somite is lost. So the way to think about it is that the top half of the C8 joins the bottom half of the C7, and the bottom half of the C8 joins the top half of the T1. And then, clinically we see that in the difference between the cervical and thoracic vertebra. Okay, and that is why there's no C8 vertebra, and that is why, above C7, C7 and above, all the nerve roots come out above the vertebra, and then below, from T1 onwards, they come out below the vertebra. But clinically, we see this in herpes zoster syndrome. So I said that the somites and segmentation forms this primary body map. But if there is a patient that get an initial infection with a herpes virus, with a varicella zoster virus, they present with chickenpox, and then that virus lays dormant, inactive in their dorsal root ganglia, and then for some reason, it's typically immunocompromised, or they don't fully understand the process yet. But when a patient is more ill, might have a cold, or might feel under the weather, or might be tired, and then they get this breakout of herpes rash, and so it reactivates, and then it travels from the dorsal root ganglia down the nerve body, and then in the skin that the nerve innervates, you get this blistering rash. And the rash is isolated to the dermatome because the virus transmits down the nerve root and doesn't cross between nerves, at the level of the dorsal ganglia, and it's ultimately contained by the immune response. But what you have clinically is you'll have a patient, they'll describe a burning rash that might actually precede a burning rash, or they might just describe burning symptoms that might precede a rash. So they might say they had a bit of burning for 2 days, and then a blistering rash appeared. And you can see here it is, the redness, the erythema on day 1. It begins to blister, and then as it dries up and encrustates, you get this macular erythematous rash that is left behind. And it's key to recognize, because in some cases there is advocation of the use of antivirals such as acyclovir with early recognition, and so as well in the ED department, if you pay attention to some of your seniors, what you might see is them trying to very closely look at the torso or wherever this rash has appeared to see, 1, does it look to cross any dermatome patterns, and 2, does it cross the midline? Because it shouldn't cross the midline if it's staying in the dorsal root ganglia along one side. So a loose pathognomonic description of this rash would be that it doesn't cross the midline and that it doesn't cross dermatome patterns. And so what we have is we've got a trilaminar disc at this point around day 22. And on the dorsal aspect, condensation to this paraaxial mesoderm, and at this, around a similar time, you get neurulation in this dorsal ectodermal layer, and so what now needs to happen is we need to create the 3D structure of the embryo, and so you'll have this process of folding, the formation of a tube within a tube, a tube of endoderm surrounded by mesoderm with a tube of ectoderm surrounding that, the external surface. And so as the cranial end is neurulated, it forms a presumptive spinal cord in the neural crest cells, but it also provides rigidity to the dorsal aspect of the trilaminar disc. And if you think about a piece of paper that you fold, if you fold it perfectly in half down the midline, it wants to the paper wants to fall ventrally. It doesn't come back over the fold that you've just created. And so that sort of physical process occurs in this trilaminar disc as well. You've created this axis on the dorsal aspect, so the natural physics would be to fold ventrally. And this is supported by this yolk sac that occurs on the ventral surface as well, that doesn't grow with the embryo, but effectively, again, acts as a physical anchor for the embryo and encourages the process of ventral folding. Now, the ventral folding, if you think about it, is occurring in two aspects. Clearly, it's folding in 2D into a 3D structure, but it has to do it cranio-caudally and also left to right at the same time. So when we think specifically about cranio-caudal folding, we've already described here on the previous slide that the developing notochord and somite stiffen the dorsal aspect, but at the same time, the neural plate, which we'll discuss in the next slide, this neuroectoderm, initiates the process of cranio-caudal folding, because what happens is that there is growth cranially. And again, if you imagine as something grows along an axis, the natural physical process is for it to fold forwards if it grows, if it extends beyond an edge. So this is actually a very key process, because the most cranial parts of the disc aren't actually the brain itself, aren't any of the cranial structures, but they are in fact the most cranial aspects of is the septum transversum, the presumptive diaphragm, and then just caudal to that is the cardiogenic area that's going to form our heart. And then you get the oropharyngeal membrane, the cranial opening of this gut tube. And so you need this forward growth of the neural plate, and then this cranio-caudal folding. So these cranial aspects can be that would be here, can fold round and come in to the right area, because what you have here, if you imagine that this is actually where your presumptive diaphragm embryonic cells are, they come in and they fold, they sit into where the diaphragm would be, this sort of like midline cavity area, and then this bit here was going to form our heart. Again, that sits, and it with the process of folding sits right above the diaphragm, and then this bit, which is going to form our cranial most structures in the embryo, now is at the most cranial end. And then, like I say, so the folding is going to bring these two into the presumptive chest area, and then as a result of all of this folding, the embryo is now a sphere that's covered in ectoderm, with the exception of the umbilicus here at this area here. And so we're going to talk now about neurulation. When considering neurulation, it's four distinct processes, and we'll discuss the clinical consequence of these four processes. But first, you get formation of this neural plate, this blue bit here on the trilaminar disc. And then you have shaping, such that it starts to look more like a recognizable spinal cord. There's bending to bring the sides together, and then closure once the two edges come together. So formation occurs because of the elongation of the ectodermal cells to form a single layer of neuroectoderm. And there's not much more to it. Like I say, it just forms this neural plate here. But what we need to do now is we need to shape that plate such that you have a chunkier cranial end that's going to form our brain, and then you have a thinner caudal end that's going to be the spinal cord. And it comes back to this process of convergent extension that we discussed earlier. There's lengthening in one axis and shortening in another, and so you have greater rate of lengthening occurring in the area of the spinal cord, and this results in a broader cranial aspect. The physical consequence of this, though, is that if you imagine trying to fold this whole neural plate, the edges aren't going to come together at the same time. So when you fold it, you'll fold it along this median hinge point, but also it necessitates the existence of dorsolateral hinge points just here, such that when the process of folding occurs, these two edges come together at the same time as these two edges do here. So again, typical exam question talks about the process of folding, and it's just important to remember that there's these dorsolateral hinge points as well. And then finally, closure. Now, this again comes back to this idea of homodimeric receptor interactions. These are molecules that will only bind to identical molecules. And so we know that the ectoderm is going to form part of our skin, the epidermis, and that clearly it's forming parts of the CNS, the spinal cord as well. So what happens is in this ectodermal layer, the neural plate cells that are undergoing this process of folding and closing, they start to upregulate N-cadherin, and then ectodermal cells that are going to form our epidermis and our skin will start expressing E-cadherin. And so the cells expressing N-cadherin bind to other cells expressing N-cadherin and close, and then the cells expressing E-cadherin bind solely to other cells expressing E-cadherin. And so you get this distinction between ectoderm that forms skin and then ectoderm that's going to form our neural tube. And then, the ectodermal cells caught between the two areas actually form our neural crest cells. And there are two reasons for this. You've got, like as you did before with the blastocyst and the inside-out polarity, what you have here is you have cells that are receiving both signals from E-cadherin expressing cells and N-cadherin expressing cells, but also, again, back to one of these early concepts of morphogens, this notochord creates a gradient of morphogens going down this way with a opposing gradient the other way, and this includes lots of key embryogenic molecules such as Wnt, WNT, and bone morphogenic protein BMP, but that's beyond the scope of this course. And so the clinical consequence of the neurulation are neural tube defects. The general term for this is dysraphism, a defect in the vertebrospinal cord or nerve roots, and when it leaves an open when the closure is open with the skin and flush with the skin, it's called an open neural tube defect, and that occurs in 0.1% of all births. And then obviously non-compatible with life, you can have this cranio-rachichisis, which is just complete failure of closure along the whole length of the neural tube. And again, going back to key embryological nomenclature, the term chysis tends to refer to an abnormal splitting or opening, and later in the organogenesis lectures we'll discuss gastrochysis. Now, if the dysraphism is actually localized, then only part of the neural tube is open, so myelochysis, the spinal cord aspects are open, but actually the cranial aspects are closed, and this is also known as spina bifida aperta. Now, if you have the opposite of this, and then you have the spinal cord is normal, but there are issues with the brain, then you can have anencephaly, and that's obviously not compatible with life. But then the more common types of open neural tube defects, these defects that you see clinically at birth. So there's a myelomeningocele. So here, the neural tube and the surrounding membranes, i.e. the dura mater and the arachnoid, protrude, leading to a sac, a seal. okay, myelo-meningocele, the spinal cord, the surrounding meninges, and a sac. It's all derivative in the name. And then you have the meningocele, where there is no surrounding sac, or there is no surrounding spinal sac. But you still get this protruding lesion. And then you get these closed neural defects that actually are in 2% of the population, spina bifida occulta being the most common. And you see them as a mark on the skin, be that a tuft of hair, a mole, an angioma, a dimple, or a lipoma. And effectively, there is the protruding of spinal canal contents, but they're covered with the ectoderm, or the skin ectoderm that we discussed earlier. And it comes back to, again, a key clinical recognition, tool and understanding of embryology is that when it comes to pathology in the adult body and in the fetus and the baby, if you think about the likelihood of something occurring in the midline as a true pathology that is intrinsically determined and not due to something like trauma, it's actually quite challenging. So whenever you spot a lesion that's in the midline, or a lesion that's symmetrical, you always should ask yourself, is this developmental? Is this due to an issue in the process of embryogenesis? And that concludes part 2. So in this part, we discussed segmentation, we discussed folding, and we discussed neurulation, and then we briefly discussed the clinical consequences of these and how you would recognize them clinically. In the next and final part, we'll cover the whole of organogenesis. We'll discuss the formation of the heart, the gut, all the organs surrounding the gut, and then we'll finish on discussing about the formation of the internal and external genitalia. Thank you.